Hello, hello, everybody. Happy Tuesday. Good afternoon. Give you all a minute to get connected. It is good to see everyone today. Some of you are enjoying your lunch. Those of us on the East Coast, it's in the afternoon for us. You might be getting that afternoon lull. So hopefully this will invigorate you for the afternoon. My name is Anissa Mitchell. I'm with PMD Alliance, and I am excited for today's program, Living Well with Parkinson's, Sowing the Seeds. And this is actually one of a 4-part series that we're doing in partnership with our friends at Amneal. You're going to receive more information in your email about the other 3 programs, so stay tuned and keep your eye out for those. In the meantime, I would like to invite you to hover at the bottom of your screen, look for that chat button, pop open your chat. That's where you're going to ask your questions today. Give us a shout out. Let us know where you're all joining us from. We love to see where everybody is at. And I'm going to introduce our speaker. So with us today is Dr. Fiona Gupta. She is the director of the Movement Disorders Outreach Program and assistant professor of neurology at Mount Sinai Health Systems. She has authored many publications and has spoken at national and international congresses, works with many advocacy groups related to Parkinson's and deep brain stimulation, and has received a lot of accolades in her career and has been actually nominated as the most compassionate physician for her graduating class. She's been featured in Top Doctors, has regular appearances in the media, including being featured on Fox and Friends, The Better Show, Sirius XM Doctor Radio, and has made appearances on CBS in New York, ABC New York, The Hannity Show, PBS, a variety of different stations. So she is very well versed in what she's getting ready to talk to us about and has been in practice for over 10 years. So I want to welcome Dr. Gupta.
Thank you so much. I want to thank the PMD Alliance and Nissa and Kelly and just everyone that plays such a big proactive role with educating patients and caregivers and clinicians. It makes a huge difference. I love the fact that you asked where everyone's from, and we're seeing not just around the country, around the world, which is so terrific. I'm sure it's all times of the day and night. So I really appreciate everyone joining, particularly here in New York City. We're having a beautiful day. So it's really nice that you could, stop and spend some time on this. And it's a pleasure to be here. As a neurologist, I'm a movement disorder specialist. I do have a subspecialty area of interest in Parkinson's as well as neuromodulation, but also in wellness. Wellness in Parkinson's plays a huge role. And I'm a big believer in what we call living well with Parkinson's. And something that I, helped coin was sowing the seeds to live well. And I'll give you that acronym. It's a little bit of a secret, but what SEED stands for. So I'll give a small talk and we'll kind of incorporate the seeds throughout. So again, really, really such a pleasure to be here. So couple key things, and I think, this is just meant, you guys are a very educated group. This is just meant to kind of talk a little bit about Parkinson's, where we stand, and again, lifestyle measures. And that's when I'll kind of bring up the secret for what SEEDS is. So about 1.5 million patients have Parkinson's at this point in the US. And that number is actually increasing. It's increasing not for bad reasons, but because patients are living longer. We have better treatment options. We have better therapies. There's a much more emphasis on lifestyle measures to help patients do better and, and have more control over their clinical course. I think we're diagnosing patients a lot earlier. Prior to, we would diagnose patients, they might have had a little bit of a tremor or some slowness, and the doctor would say, well, come back in a year or so. Now we know there's importance of diagnosing and treating now, even if it's lifestyle measures, because you want to really take control. And then probably more in the way of some environmental factors and so on as to why the numbers are increasing. One thing that's interesting is that Parkinson's was actually described by James Parkinson in 1817. He was an English family physician, so he's a family practice doctor. He had 3 of his own patients, and he observed 3 patients on the streets of London that had kind of that forward flex posture, a little bit of a fascinating walk, the diminished arm swing. And he actually wrote an essay called Essay on the Shaking Palsy, which is very interesting. You could pick it up at most libraries now, and I tell my med students to all read it and so on. But I think as a whole, it's really, really informative. And what we saw back in 1817 still holds true to this day. So again, second most common neurodegenerative condition. The numbers are increasing, but I think there is more awareness. As an educator, I think the best thing a patient can do is be their own advocate, but have good advocates around them. And that includes the PMD Alliance and other networks that are really helping to educate patients. So again, I commend you significantly on that. So patients ask me all the time, how did I get Parkinson's disease? The cause is still unknown, but we do believe that it might be a combination between genetics and environmental factors. True genetic Parkinson's is fairly rare, usually very much younger onset. But if we can kind of blend that someone may have a genetic predisposition to developing Parkinson's and then something in the environment causes it to kind of set into play, that might be sort of the speculating factors, this two-hit theory. Things like rural living, well water, pesticides, herbicides also may contribute. And also age is a significant risk factor as well. And what Parkinson's is, it's a neurotransmitter deficiency of a chemical in the brain called dopamine. So we all make dopamine. It helps us to control how we move. It helps us to control the speed of movement. It helps us to even control how we feel. So we know that Parkinson's affects dopamine production quite early on because of loss of the dopaminergic cells, and that's what causes difficulty controlling movement. We also know that there's other transmitters that are deficient, like serotonin and norepinephrine, for example, which are why so many Parkinson's patients have non-motor symptoms: mood, anxiety, depression, apathy, sleep issues. All of that ties into various neurotransmitter deficiency. So I think the key really is identifying each patient, figuring out what are the most pressing symptoms, and treating them accordingly.
Hey, Dr. Gupta, real quick, can I ask you to put it on the full screen view so people can see it a little better?
Sure.
Thank you.
So slideshow, yeah. Okay, is that better? Good. Thanks for reminding me. So we do know that Parkinson's actually starts in the lower brainstem, which is sort of in that area again, which controls how we smell and how we sleep and constipation and so on. So that's why so many of the symptoms that start before the development of even motor symptoms of Parkinson's, like stiffness or slowness or tremors, these premotor symptoms can occur. So again, the constipation, the sleep issues, the yelling, the talking in the sleep, the vivid dreams, they are very commonly there prior to even a diagnosis of Parkinson's. As the condition continues to progress, that middle red area is sort of where the dopamine is made. That's when we start to see the motor symptoms, which are tremor, stiffness, slowness, and so on. But you can see that continued progression involves kind of more than just the middle of the brain, but also the cortical regions, which account for mood and cognition and speech and swallowing and falls and so on. So I think it is important to individualize these patients, figure out where they are in the staging, and be proactive and treat them as best as you can, depending on each stage. So certain signs and symptoms of Parkinson's are, again, there's very much of a clinical diagnosis. MRIs of the brain, blood tests don't really help. We do have supportive radiologic imaging like DAT scans and so on, but it really still is a clinical diagnosis. And not everyone is alike. There's no two people that are on this talk that are alike, no two people in my practice. Everyone is very different, but we're looking for things like slowness, which is bradykinesia, which, your doctor may have you do finger taps and open and close the hands and things like that. Stiffness, sometimes balance issues, sometimes tremor. Not all patients have tremor. There's a lot of misconceptions about that everyone has to have tremor for PD. But again, everyone experiences symptoms differently, and we're looking for these 4 clinical features in making a diagnosis. 2 of the 4 is clinically possible. 3 of the 4 is clinically probable. So that's kind of what is being looked at. And sometimes you have to see a patient, multiple times. You may not see it at the first visit. You may want to follow them. You might want to, test them with medication or, really work on other metrics till we make the diagnosis. But it really is a strong clinical foundation between patient and caregiver. And then beyond just those 4 cardinal symptoms, there's other symptoms as well. Oftentimes, we're all guilty, especially nowadays when we're on Zooms, of stoop posture, right? We're looking down, our shoulders are forward. And that's very much holds true for a patient with Parkinson's, and that the posture can become more forward flexed, but they're not even aware of that. So I always say to my patients, stop for a second. We should all do this on the call. Get your shoulders back, get your chin up, sit up as straight as you can, like, you're being pulled up on the top of your head, and try to remember that position. Because if you can kind of incorporate that type of posture exercise into your daily routine, you'll be surprised how much change you can have. Small handwriting can occur, what we call micrographia. Patients say that, especially with longer sentences, the handwriting can become smaller and so on. But guess what? Again, the power of Parkinson's. The more you put into it, the more you'll get out. I tell all my patients, if there are handwriting issues, don't give up. Get one of those pads that kids learn to write on, the big line pads, and write 10 minutes a day. And you'll be surprised. Patients come to me all the time and they're like, yes, it worked. I got it back. So again, it's imprinting the brain. It's really trying to work at any symptom that might be there. Decreased arm swing can occur, sometimes cramping in the lower extremities, swallowing issues, facial expression changes, shuffling gait, sexual dysfunction, and so on. So I think the key really is that there's such a myriad of symptoms that can go along with Parkinson's. It's more than just the slowness or the stiffness and things like that. And this is why you should be aware of your head to toe approach, how you're doing, what is there, what is not there, and then work at it. I'm a huge believer in our physical therapists, in the Big and Loud programs, in the Rock Steady boxing programs. I mean, you name it, the LSVT, because a lot of that really takes into account fixing these deficits. And then we mentioned non-motor issues. So the things that might occur even before the diagnosis of Parkinson's: constipation, depression, anxiety, sleep changes is a big one. And then non-motor in the context of Parkinson's, patients can experience apathy, fatigue, lightheadedness, cognitive issues, smell issues. I mean, you name it. And this is why I think it's so important to talk to your doctor about exactly what you're feeling from a motor and non-motor perspective, because we work at each symptom differently. I have a whole team of my psychiatrists and psychologists that work with me to really work on the mental health. I have a team that helps working on the cognitive health. We have our physical team. So there's a lot of things in terms of other services coming together. But the key is really identifying what are the biggest deficits and really going after them and working at it. So again, the diagnosis is very clinical, made by a history exam, and then following out someone's clinical course. And this is the key thing, is how can you take charge of your Parkinson's? And this is why I always put the patient in the middle. It really cannot just be the patient and one doctor, or the patient and the caregiver and a doctor. You need a team approach. And most centers, you'll be surprised, whether you're in the middle, different parts of the country or world or things like that, you can actually seek out a team. And like the PMD Alliance is a perfect example for helping identify resources and so on. But the patient has to be in the middle and everyone working together around them. The neurologists, the caregivers, our nurses, support groups like this are hugely important. The primary doctor should be looped into every single visit by being CC'd by the neurologist, because that plays the role. Again, I can't say enough about our physical, occupational, speech therapist, psychologist, social worker, other ancillary services. But that's really the most important thing, is building a team around you, because the more communication and more flow between providers, the better you're going to do. And I think the key really is working with your team. Symptoms change over time, as does treatment. I'm a big proponent of patient diaries, really helping patients advocate for themselves by writing down what their symptoms are. I always say it's not necessarily good day, bad day in Parkinson's. It can often be good hour, bad hour. So even breaking up the day, in terms of diaries, morning, afternoon, evening, night, and helping, patients will just tell me, are they on, are they off? Is there dyskinesia? What are the major issues? But really taking charge of, your symptoms and providing that communication to your healthcare provider is really paramount. You want to discuss any medication related concerns. And I always say, you have to be your own advocate, but people around you who care for you are your advocates. So family members or a key support person are so wonderful, I think, in terms of helping chime in on some of the appointments, especially because many of our patients with Parkinson's are not even aware of some of the symptoms they're manifesting. And the caregiver or, loved one plays a big role with providing that history. So again, I cannot say enough about really being prepared, chronicling, journaling your symptoms, and then really sharing that with your provider. So let's go to that sowing the seeds. This is an acronym that I'm really proud of because I think it really takes into account many of the things that patients need to do to live well with Parkinson's. So the first S in seeds and sowing the seeds is for sleep. We're going to talk about sleep and how it's not just quantity, but it's also quality of sleep. The next E is for exercise. The only thing that I can tell you that will slow the progression of Parkinson's at this point is exercise. And so it's so important. And like I said, it's not just about how much you're doing, it's also about the quality of exercise. The next E is for eating well. We'll touch on diet and why sometimes smaller, more frequent meals are better. And things like focusing on fiber, balancing out protein and limiting fatty foods or sugars, things like that are very important for brain health. The next, so S for sleep, E for exercise, E for eating well. The D in my seeds is drink water. I think we're all very, very guilty of being busy, or the day goes on, and when you ask a patient how much water they've had, it might be just a few sips with their meds or things like that. So hydration for a patient with Parkinson's is crucial. Patients are prone to constipation, lightheadedness, low blood pressure, and things like that. You'd be surprised how much better they feel with just adequately hydrating. And then the last S is for stress reduction, socialization. I know that's been very difficult in these last year and a half, the socialization aspects, but even just keeping up with friends and family through a platform like this, staying on top of things, staying, connected plays a big role. And I can't tell you, when you socialize, it's the best form of mental activity. Your brain is making so much of its own, synapses and really plethoras of dopamine and things like that. So we do know that treating early may be important in terms of living well with Parkinson's. And I'm not saying when a patient's diagnosed, they go to meds. If anything, you have to be very careful about your med list and what you start and when you started and what the dosage are. But I'm talking about working on the lifestyle measures that we talked about: the exercise, the sleep, the diet, the hydration, the socialization. And again, that lifestyle modification piece is so crucial to maintain overall health and quality of life. So I always call it like a pie. Probably the lifestyle piece for me is about half of it. Then there's meds, and then there's potentially surgical options or trials or things like that. So I always say to my patients, you cannot be physically well unless you're mentally well, and vice versa. So your emotional health is as important as your physical health. And a lot of patients either brush it under the rug, they don't talk about it. There's a little bit of anxiety to talk about mental health, but it makes such a big difference. So again, the key really is maintaining mental health, incorporating lifestyle measures, exercise and diet, but taking action about your mental health, taking a stock of it. How am I doing? Could I do better? And like I said, we're very fortunate to have a lot of providers that are even doing virtual visits now to go over psychology and psychotherapy and just discussion. So you could build that team around you by adding advocates from a mental health perspective. It makes a big difference. So the exercise, eating right, meds, consideration of surgery, and complementary alternative approaches really do balance out, and not one here is more important than the others. A lot of people think they're diagnosed with PD, they have to go right to meds and that's it. But for me, meds are really going to not work as well unless the lifestyle measures are there. So exercise, again, sleep for S, E for exercise. In my seeds paradigm, we know that patients need to get moving. Not only is exercise good for balance, gait, coordination, physical functioning, strength, overall quality of life, it plays a huge role, again, in disease modification, slowing the progression of Parkinson's. Since I started in practice about 15, 16 years ago, there were some good exercise programs. I mean, we had in New York, we have a great, dance program, patients were walking, they were doing things like that. But I'm just so pleased by the explosion in the last decade of all of the resources of exercise in Parkinson's: the rock steady boxing, the LSVT, the big and loud, dance therapy, the Tai Chi, work on some of the, coordination bikes and things like that. But patients ask me all the time, which exercise is the best? And I always say it's all good. If you can balance out some cardio, doesn't have to be intensive, but light cardio, strengthening and stretching, and really make an aim for 30 minutes, 5 times a week, you're really doing yourself a good service. And I know it's not always easy, and there may be days that might be skipped, but if you can really focus in on that, it makes a huge difference. So really the exercise component is something I ask all my patients about. We discuss it. Even those who may not have as many resources or might be more limited from a mobility perspective can still do a lot of chair-based things and work on stretching and so on. But exercise is paramount in order to live well with Parkinson's disease. So we talked about diet. Remember, that's my next E and C's: sleep, exercise, E for eating well. Nutrition is important. Nutrition in Parkinson's in particular, brain health is really all about nutrition. And we really want to take into account a couple things. Number one, I have a lot of patients, because they've lost some smell, they've lost taste, they don't feel that well after a big meal, they stop eating. And what happens there is that the muscles start to get wasted. They become more, the posture becomes more flexed because they've lost a lot of sort of stability. They may have atrophy of other muscles, and that just really wreaks havoc on overall strengthening. So maintaining a proper weight is so important to avoid weakening your immune system or causing muscle wasting. Things like constipation really need to be dealt with. And that's, for me, the F and the F: fiber and fluids. I like the fiber if you can get it in a more dietary fashion, but I'm not opposed to some of the over-the-counter remedies that have fiber in them as well. But that's not going to work unless there's fluids. Especially when women, supporting bone health is very important, especially as things go on. And so discussing, potentially vitamin D or calcium with a provider. I like to get levels on patients so I know where they are and then determine if they need the supplementation. And then I think there's a lot of misconception around the protein aspects. Do you stop protein? Do you have to, is it interfering with the levodopa and so on? I think the key really is individualizing each patient. Not all patients are going to need to restrict protein. Some may, especially if they're having motor complications or a protein interaction, which is kind of fighting with the medication. But that is something to talk to your doctor about. I think the dietary aspects are important, and you don't want to restrict, any major group based on sort of fear of med interaction. So that's the E for exercise. E for eating well. We'll go up to the S, the first one, which is sleep. So it's over 60% of patients with Parkinson's will have a sleep issue. It's a major, major issue. And when we sleep at night, we have these little janitors in our brains, and they come and they clean up all the toxins, and they restore dopamine and all those other transmitters that are so important. So if you're not getting an adequate sleep with regards to quantity or quality, it really is detrimental. I spend a lot of time fixing patients' nights, in turn, which leads to better days than just adding more meds to the day or, doing things like that. Because you'll be surprised, if you can get a patient with Parkinson's sleeping better, they do a world better. It's really pretty amazing. So sleep disturbances are things like insomnia, feeling too sedate during the day, the REM behavior disorder I talked about, which can occur early on or throughout the spectrum, which is the yelling, the talking, the moving. That's also something to consider. And then some patients also have other kind of sleep comorbidities like apnea and so on. So the key thing is talking about sleep, determining, good sleep habits. I'm a big proponent of sleep hygiene, which is trying to go to bed same time every night, cool, dark room, paying attention to kind of circadian rhythms, not staying up too late, not waking up too early. If patients do have sleep fragmentation, which is where they wake up, they fall asleep okay, they're just up every couple hours, we work on measures with our cognitive behavioral therapists to work on that, not just laying in bed and being anxious about sleep, other practices and so on. But sleep is something that every patient needs to equally take into account as exercise. It really makes a big difference for brain health. And then the medications with Parkinson's. So we have come a long way. Obviously, our best medication is levodopa, which is essentially giving the brain the dopamine from an exogenous source. But then there's other medication. There's dopamine agonists, which mimic the dopamine. There's MAOB inhibitors, which help to preserve the dopamine. There's the CONT inhibitors. Now we have new therapies that are non-dopaminergic, that work separately than the dopamine pathways, like istradafylline, Gocovri or Amantadine are used. And, in the last couple of years, we've had a really great presence of the on-demand therapies, things like inhalable levodopa or apomorphine that's injectable or sublingual, which can help as rescue-based therapies. And the reason I like those is that patients have, discretion as to when they want to use it, and they have much more control. It's hard to give a patient a fixed dose regimen as every day is so different. So I'm a big proponent of working with my patients, figuring out ways that we can give them more control over the meds. They know themselves better than anyone. Just because your doctor says it has to be at every 4 hours, you may need it certain times every 3.5, or you may not have to. You can go longer than the 4. So it doesn't have to be a fixed interval schedule, but that's why I do like the more on-demand therapies, just because of it gives patients a lot more flexibility. Again, as I mentioned earlier, surgical therapy, including deep brain stimulation, is one of my main areas of focus. It's basically thinking of it like an electric prescription, or a digital prescription, using a target implant that goes into the brain to really try to neuromodulate the circuit that's not being driven in Parkinson's because of the lack of dopamine. And so basically, by putting in the lead, you're bypassing the need for dopamine. In many cases, you can reduce the medication pretty well, but you're really trying to use this kind of electrical stimulation to really get that motor and function, and abnormal signals that are being blocked. Normal signals you want to facilitate. So deep brain stimulation is not appropriate for everyone, but I do tell my patients, to be the most educated about it, you should know, am I a candidate? What is it going to do for me? What's the closest center? What are their statistics like? And go from there, because it is really life-changing for the right patient. And we have many studies that show deep brain stimulation is far superior to even the best medical therapy. So if a patient's being put on what we consider the most optimized med regimen, deep brain stimulation patients do much better, particularly with quality of life. It's reversible, it's very adjustable. My team has the ability to adjust the pacemaker in many ways, over 50,000 settings. So if things change over time, we adjust the DBS. And, in the beginning, there was really just one company. Now we have 3 companies that all have different modes of action and different things in technology. Now, one thing that I really like is one of the companies has a virtual remote clinic. So where I can almost be like sitting with my patient in clinic, but doing all their programming while they're at home. I mean, things have really evolved. So if you are interested in DBS, I would definitely seek out an opinion as to if you're a candidate and, kind of what centers are available to you. But it is quite life-changing for the right patient. And then, complementary approaches. I get this asked all the time. And I'm not a non-believer by any means. I think it's so we don't have necessarily the data, but I do believe that they may play a role as long as you're telling your doctor as to kind of what you're taking. I do believe in the role of herbs and foods and certain vitamins and so on. But we do need more research. You might have heard of things like certain foods like fava beans or mucuna, things like that. A lot of my patients will say, well, I ate some fava beans last night. So, well, to get really the properties of like the full dopamine response, you probably need 1,000 cans, but that's okay. It's still the properties. It's still uh, nutrition supplement. Certain vitamins, bioenergetics can be used. And then even just, things like acupuncture, biofeedback therapy, manual therapy, massage, all of that is very good, particularly for that last S, which is reducing stress and socializing and things like that. So I think complementary approaches can be used. It really just has to be discussed with your provider. And then again, I talked a bit about you cannot be mentally well unless you're physically well. You cannot be physically well unless you're mentally well. They go hand in hand. And managing psychological issues is very important. Patients with Parkinson's will commonly develop depression, anxiety, lack of motivation, or apathy. And I always tell my patients it's important to realize it's not you. This is not the person you've become. It's not something, that your personality has changed. It's very much chemical. It's very much just like the dopamine deficiency. There's serotonin deficiency, norepinephrine. There's other transmitters that really play a role in mood that are deficient in Parkinson's. So the first step is identifying it and then seeking out the help. My patients who know me know I'm a minimalist when it comes to meds. If I can treat something from a non-pharmacologic perspective, work on counseling, work on, biofeedback and things like that, I'll definitely try that. But medication can play a huge role too, especially with any type of psychological issue. So again, seek out that person as part of your team for psychological help. Your neurologist can definitely help you find that as well, but it plays a big role. And then education, the best way to stay on top of Parkinson's, the best way to beat this is stay informed. Things change over time significantly. Even in the last couple of years, we've evolved so much with new therapies and pipeline therapies and so on. So keeping yourself informed kind of like through like seminars like this and, ongoing readings and asking your doctor about new things, they play a very big role. And what you learn really can help tailor your therapy. I have patients come in all the time and say, I read about this. Is this right for me? And, absolutely it is. So, in many regards. So, it is important to stay informed. I like these resources. I'm sure the PMD Alliance can also give you some other resources too. But certain things that you can find information from a credible source are very important, I think, rather than just Dr. Google and so on. So something that's a little bit more dedicated. And the one thing I did, I started a caregiver support group at Mount Sinai where I am, just because I was finding that the caregiver role is so difficult in Parkinson's. Like I said, it's not just a good day, bad day thing. Patients really can change. It's like a roller coaster. Some hours that are good, some parts of it are not as good, and it can be very difficult, for the caregiver, particularly because there's so much in the way of motor symptoms, but non-motor symptoms and so on. But I tell my caregivers, try to attend the appointments, help identify changes. You can help with meds and things like that, but be realistic about the care. Take time for yourself. I think that's a huge, huge thing. It's not easy, but if you can just have that level of mental perspective, taking that time for yourself, seeking out friends and support groups, invariably, patients are going to do better. So that caregiver role, like I said, is not something I underestimate by any means. It really is important for caregivers to realize that their role is so important, and they really, should seek out resources as well. So again, if we can kind of go back into the seeds, sowing the seeds for living well with Parkinson's. S is for sleep. E is for exercise. The next E is for eating well. The D is for drink water. And the last S is for stress reduction, socialization, and so on. If we can make sure patients are working with their team, following the diet, the exercise, the sleep, having that attitude, the positive attitude, involving family and friends, and just really educating themselves, these are all things that make up the recipes for success. It makes a tremendous difference. And the face of Parkinson's is changing tremendously. Even though we have levodopa that has revolutionized the treatment that was kind of first put out in the 60s and 70s, we're now realizing there's newer medications. There's different forms of levodopa. There's a lot of promising new approaches that are under investigation, improved technology for deep brain stimulation, and so on. And so really staying actively involved, being your own advocate is probably the most important thing you can do. And then again, building a team of advocates around you and working on sowing the seeds to living well with Parkinson's is really the best approach. Stay active and stay involved. And again, I always end with this slide because the first, most important concept is putting the patient in the middle, working with all the other providers, and then basically realizing that the most important team member is you, and really being proactive with your care. Thanks.
And Dr. Gupta, somebody asked if you could share that screen again with the resources. Are you able to put that back up? Sorry, I didn't catch you before you took it down.
Oh, that's okay. Towards the end.
And I have been collecting the questions, and I tried to keep them in categories. So after we share that screen, thank you.
Thank you.
Mm-hmm. Awesome. You can leave that up for a minute in case people want to copy any of that information down. So I have a couple questions in regards to medication. So I'll start off with those first. One person wanted to know, when is the right time to start medication? And then kind of a follow-up to that is, another person said that their doctor said Cinnamon only works for 10 years. What is your opinion?
Yeah, so this is a very individualized approach. I mean, you can't really say there's a right time. Everyone is so different. I start medication when a patient needs it. I don't hold off just for fear of cinnamon or anything like that. Whatever you start, though, you want to make sure your dosing is judicious, that you're not overdoing it. But really when a patient needs it, whether it's quality of life or impairment of motor symptoms or non-motor and so on. I have many patients who are young, 40s and 50s, who are taking medication from the start because they need it. They're working full time, young families at home, and other patients who, you know, are a bit older, but, you know, really because the symptoms are impacting what they want to do, the exercise or the socialization and so on, we start it. So there's no right or wrong in that, but the whole approach of you just wait, I think is the wrong approach. We know that if you can start it, but you start it, you know, and you're conscientious with your dosing, your patients will do better. I don't believe in that Cinemet stops working at 10 years. Again, it's not that it stops working. It's always going to continue to work. But what happens in the beginning of Parkinson's, patients take their Cinemet, they do very well. They may only need 3 doses, 4 doses at last. They don't really get the wearing off and so on. But as the disease continues to progress, that window, the therapeutic window we call, gets smaller and smaller. And therefore, the medication, patients need to take it more often. It can be complicated by the dyskinesia or wearing it off, but Cinemet's going to continue to work for the symptoms it works for. There are symptoms that Cinemet doesn't respond to very well, especially as the disease progresses: falls, freezing of gait, speech, or swallowing. And those are things that have to be worked on separately, but Cinemet doesn't really have a finite period where it stops working.
Fantastic. All right, so I have a few questions in regards to eating, diet. So one person wanted to know if you could talk a little bit about the gut-brain connection.
Yeah, I mean, the diet aspects are very important to take into account. We know that Parkinson's is as much of a gut disorder as it is a brain disorder. What happens is there is quite a bit of what we call gastroparesis or gastric slowing. And so basically, when a patient may take their medication, it doesn't get absorbed, especially as the condition progresses. So what might have kicked in about 15 to 20 minutes often can take over 30 to 60 to 90 minutes. Patients often have dose failures and so on. So being more aware of that gut-brain connection, I think, is very important, especially as to how the medication response is. We also know that a lot of the pathology that we see in the brain, like Lewy body deposition, alpha-synuclein, we're finding in the gut. So a big key part of that is keeping patients' guts as clean as we can. I do have patients who do different probiotic supplements. I think this is where the hydration comes in, management of constipation. But, you know, GI health is pretty big when it comes to treatment of Parkinson's.
Fantastic. Another person wanted to know if you could talk about ways to increase nutritional intake when someone has lost taste, or they're just apathetic in general and don't have much motivation to eat.
So that gets a little difficult, but this is where I always say to my patients, it's going to be very hard to have one big meal at a time. Especially if you have the apathy or the lack of taste or smell. So smaller, more frequent meals is something I really, think is very, very important. Enjoy what you like. You don't have to restrict things so heavily. A lot of my patients really do well with that bowl of ice cream at night. That's okay. Try to really stimulate the taste buds. Sometimes super salty, super sweet, super sour things just to get the taste buds going prior to a meal can be helpful. But I always encourage that patients really need to have a better understanding and idea of what their diet is. Journaling, working with a nutritionist can also be helpful. But the last thing you want to do is stop eating because of sort of the apathy.
And you mentioned sweets. So I've heard many people say that their loved one or they themselves have become like this big sweet eater, even if they weren't before. Is this something related to the disease itself, or because of their ability to taste the sweets better?
No, I think it goes more with the kind of what we call impulse control issues that sometimes can occur in Parkinson's or as a result of medications. I have patients on certain dopamine agonists like pramipexole or ropinirole or things like that, that really were never sweet eaters, but they started really indulging. And so I think a lot of that too might be more like kind of dopaminergic, even adverse effects of meds, things like that. But again, something to bring up with your provider, especially if it's getting to be a little bit more compulsive.
Awesome. All right. So now I have some questions in regards to exercise. So this person said, I love to fly fish. I understand there's some research that says it could be good for a person with Parkinson's. Any info on that?
I think it's perfect. I think anything you can do outside is probably the best that you can do rather than sort of being in a gym or anything like that. So I think you're getting the lovely sort of cognitive and mental aspects of benefits of being outdoors. I do think potentially the range of motion that it involves, especially almost similar to what we do in Big and Loud, a lot of big range of motion movements. It requires agility, core strength. particularly if you are standing. So I don't know exactly the research, but I think it's one of the best things. And my patients who also are very similar and do the same, just feel a sense of, significant relaxation.
All right, this is a good question. I'm sure others have it too. So, does the 30 minutes of exercise have to be continuous, or can it be 15 minutes here, 15 minutes later in the day?
No, it doesn't have to be continuous. A lot of my patients will go 15 minutes on the bike in the morning and then do their 15 minutes strengthening and stretching. So absolutely. And that 30 minutes 5 times a week is kind of a minimum. So, I mean, if you can get that, and it's great, but it doesn't have to be continuous, and anything more is, would be wonderful. I have a lot of patients who are active and they're telling me, well, I'm, out in the lawn, or I'm walking up and down my stairs all day, but no, that doesn't count. You really want that dedicated 30 minutes, however you get it, of just dedicated exercise.
Okay. And another exercise related, also tied to sleep. This person says challenge with sleep issues makes the exercise goal all the more difficult and frustrating, especially if there's other problems like back problems. Any thoughts on addressing that?
Yeah, I mean, you address it from exactly what it is. I mean, the fact that it is a vicious circle. If one of those components of the seeds lifestyle measures are not there, it's going to lead to other components not doing well. For example, someone's not sleeping well, they're not going to want to exercise or eat well. They're not going to want to socialize and things like that. So you've got to work at it. Sleep is really complex, but if it's done right and you're with the right practitioner, there's many things you can do. If it's back issues, restricted mobility, sometimes taking a little bit more cinema, towards the or meds like towards night can help with flexibility, certain types of mattresses, pillows, you name it. Just you got to identify what is the issue. Is it quality, quantity, and how can you best work at it?
All right. And I was going to go on to sleep because it seemed like a natural segue from that, but I got another diet related question that I thought was good. This person wants to know if a vegan diet with intermittent fasting helps. So you have any thoughts about a specific diet like vegan or intermittent fasting? Because I know that's a big thing nowadays.
Yeah, I mean, there's no good data on that, especially the fasting approaches. I also worry a little bit about low blood sugars and things like that, on top of patients being a little bit prone to have low blood pressure anyway. So you just have to be careful. But if it is something that's working for you, discuss it with your doctor. I think a lot of my patients feel that if they do fast a bit, they just feel better from a gut perspective. Again, less in the way of sort of the GI transit and motility issues, but definitely is something to talk about. The vegan diet, it's hard to tell. I mean, again, there's no data. The brain does need protein. So, we tend to tell patients don't take protein because of antiquated theories on, the meds and things like that. Patients can still have protein. It just sometimes needs to be spaced out with meds, or there has to be consideration of how much. But this is really where, working with your provider is important, potentially a nutritionist. But if the vegan diet with fasting is helping a patient feel well, I can imagine it would give them a lot more energy. They'd feel a little bit cleaner, kind of that, that Mediterranean approach from a vegan perspective. I'm all for it.
All right, thank you. All right, so some sleep questions. A person said another sleep disturbance was nocturia, having to urinate several times during the night. Can you talk about that a little bit?
Yeah, that's a little difficult because, again, they're not just up because they're up, they're getting up to urinate. Depends on how many, are patients falling back asleep okay? How disruptive is it? Is it more than 1 or 2 times? If that's the case, potentially starting a medication like an anticholinergic at night. We use things like Myrbetriq or Detrol preparations or things like that can be used, especially if the nocturia is quite disabling.
All right, and then someone mentioned restless leg syndrome really messes up their sleep. And they've worked with their specialists to help with dosage and timing, but could you maybe describe that a little bit for maybe those who aren't familiar with that?
Yeah, so about 10% of the patient population in general is going to have restless leg, and 70% of patients with Parkinson's have a form of it. So it's a pretty big symptom, and it does tie into dopamine deficiency. Trying to work on non-pharmacologic therapy, stretching, sometimes like an Epsom salt bath of the legs at night, avoiding like heavy exercise a couple hours prior to bedtime, avoiding a big meal or alcohol, that can help. Medications, though, we treat restless leg like we would with Parkinson's, especially at night. You may need to dose the dopamine a little bit more frequent, you may have to switch over to like a dopamine agonist, or even things like gabapentin or things like that. So there are regimens, just like my PD patients, my restless leg patients are all so different, but something to, again, really keep working on medically and non-medically.
Right. And there are those who sometimes think that their loved one or they are experiencing REM sleep behavior disorder, but they wake up and they're actually maybe hallucinating. Can you talk about how you can differentiate between the REM sleep behavior and maybe somebody who wakes up and is having a visual or an auditory hallucination?
Yeah, that's a little tricky without a good sleep study. I mean, oftentimes we have to have like caregiver input, but if a patient's actively sleeping, they're in REM sleep, that's a pretty deep sleep, and they're thrashing, they're yelling, but they're sleeping, it's hard to awaken them. That's probably more indicative of REM disorder. If someone's waking up, they're awake, and it may not be fluid hallucinations. A lot of my patients will tell me they see the coat rack in the corner and they think it's a person or things like that. That can be like visual perceptions. But I think the key is, is it occurring if patients are like pretty deep asleep, or if they're in more of an awakened stage.
All right. Related to stress is, something that certainly causes a lot of stress is fear of the future. And somebody said, I sometimes struggle with that. That's not something you can necessarily, address with a medication, certainly with some support and maybe counseling. But is there anything that you could talk about in regards to addressing fear?
I mean, I understand it completely, but I always say you take it day by day by day. Patients are doing much better. There's better ways of living longer, of treating symptoms. I mean, even when I started practicing, over 10 years ago, we have way more like improvements in quality of life and so on. So I just say take it day by day. That's your best approach.
Right. Somebody did just write in. I'm catching up now with the more recent one. Someone says, does extended release levodopa help get a person through the night, or does it stimulate the brain and keep you from a deep sleep?
No, I actually like it at night. If I'm going to use a CR, control release, maybe even an ER, I do think it does help with bodily comfort. Our brains make dopamine at night. It helps us to move around. It helps us to be comfortable. So I absolutely think it can complement a tough night.
Mm-hmm. And is it safe to take melatonin?
Depends on the patient. Yeah, something you'd want to discuss. It is one of the top 3 therapies that are used for sleep. But again, you should bring it up with your provider because you just want to make sure it's not interacting with other medications and things like that, and work on the dosing.
Okay. And then I just got another one. How important is not eating before or after meals in regards to levodopa? Like, what is I know it's individualized, but is there a standard practice of how long to wait before and or after a meal with protein?
Yeah, if someone is having the protein interaction where they clearly can define that protein will block the levodopa, then we say about 40 minutes before or after should be adequate.
Okay.
It really depends on how often someone's dosing and things like that.
Fantastic. And if there's any other questions, you guys have audience here with the physician. All right, this person just said, they're sharing that they're currently working on a website resource that will serve as an online support group, as a place to share stories, called Parkinson's Parky TV is the site if anyone's interested. So thanks for sharing that. It's always important to have resources. And I appreciate that you mentioned the importance of support groups and, speaking with counselors, seeing the social workers, having that whole team approach. For those who don't live in an area that maybe has a multidisciplinary team, do you have any recommendations of how they could access all these resources, or what they might do if they're in a more remote rural area?
Oh, sure. I have patients all the time that, will carve out their own team, just like they're doing now, just like, this Craig mentioned what he's working on. Really, they don't have to be necessarily dedicated specialists that are part of the center, part of Parkinson's. I mean, some of my patients even seek out good mental health through their local social workers or priests or church, or any of the alliance groups, any of the exercise groups. Again, bringing in your primary care doctor to part of the discussion, all of that plays a big role. So you can really still carve out that team.
Awesome. So a lot of people on here have PD, and then some of us on there have Parkinsonism. So someone wants to know how much of your suggestions really apply to someone with MSA.
Oh, hugely as well. Obviously a little bit more difficult, but still the aspects of the exercise, the sleep, the diet, all of that plays a big role, especially the hydration. So yes, that can definitely, all the seeds can hold true for Parkinson's disease or any type of Parkinsonism.
So, and again, kind of back to maybe not being in an area where there's a lot of Parkinson's resource. If someone needs talk therapy, how important do you feel it's that they go to somebody who understands Parkinson's? If they don't have a lot of options in their area of somebody who's well versed in that, do you have any thoughts on whether it could still be beneficial, or do they really need to look for someone?
As long as it's someone they're aligning with, someone that they can really work with, it's always going to be beneficial. That's going to understand them as a whole.
Awesome. And this person says, I have many chronic conditions, sometimes pinballing game of symptoms amongst them. How do people, if they have other conditions, other comorbidities, how do they sift out what's Parkinson's, what's not, and balance all that?
That's building the team around them. I have so many patients that have chronic conditions. It's life, right? Patients also develop cardiac issues, metabolic issues, things like that. But again, it's providing that team around each patient. So any type of condition that provider needs to be put in. In my center, my institution at Sinai, which is so great, is we have a dedicated electronic medical record where I automatically CC anyone that's part of the patient's care team, and they get that note so they can read it. So all of those things in this modern day and age with EMR and all that makes it a lot easier to develop sort of that multidisciplinary team.
Awesome. Well, I love your seeds approach to care. I think it's very holistic and just really a good way for people to remember the sleep, the exercise, the eating, the drinking, the water, and managing the stress will really help them live well with Parkinson's. Do you have, or related disorder, do you have any other last words of wisdom surrounding that?
Again, the whole concept of living today, living well with Parkinson's disease, sowing those seeds of lifestyle to then enhance the meds and other options. Working with your provider, or at least in New York, I'm not sure about other parts, but we're very fortunate to have multiple providers that you want to really be able to bond with and gel with and communicate with. That's a big one too. And feeling again like you're part of the center and everyone is working around you to really put you as first and center. It really does make a difference. How you develop your team now makes a huge difference as to kind of how you do in the future. And I think I saw on the chart that someone asked if I see new patients that are maybe mild versus severe. I see patients across the board of the spectrum. It's my favorite thing to do.
Awesome. You've gotten somebody to plan to make a concerted effort to drink more water and eat healthier. So that's good. And, I think you're right. Most of us are probably dehydrated and don't realize it. Can you speak? Because I think this is a really important thing that we don't necessarily think about. And it's how much water you really need to take when you're taking your medication to assure that it gets down and it can get through that whole digestive tract, because there is that slowing. Can you speak to that just a little bit?
Yeah, it's a very variable thing. It has to do with patient's body mass index, other comorbidities, making sure there's no cardiac or renal aspects. But once I know that, I'm able to advise patients. And the water is not necessarily for transit. It's more for working on constriction, getting the blood vessels to perfuse, working on, any existing fiber to get the stool down, building osmotic pressure. So in a way, there's so many aspects of hydration, but that is something you should talk to the provider about, especially with regards to how much. I just know that we're also dehydrated. This doesn't count, soft drinks and so on. It really does have to be water. And I always tell my patients what one cardiology colleague told me, many years ago: if a patient can start their day with about 8 to 12 ounces of water right by their bedside before they even get up out of bed, they're just going to have a better morning. And then you got to work at it kind of throughout the day, but something to really keep mindful of.
Right. And I know that a lot of people struggle because they don't like water, or they just don't think about it. There's not that initiation. I know that a lot of care partners have shared through the years, I feel like I'm nagging them constantly to drink water, drink water, drink water. Any tips on that?
Yeah, I mean, we tell patients that you can do some of the flavored things and so on, but to substitute with other things like juices that have sugars and things like that may not be the best. So and even again, just like we said with the meals, maybe smaller sips a little more frequently. It doesn't have to be, downing it once, but it is just making a mindful effort, which I think whether you're Parkinson's or not is something we just don't do enough of.
Awesome. Well, this has been really good. I would love everybody to raise their hand that they're going to make a concerted effort to sow seeds of wellness in their life, drink more water, try to do what they can to sleep better, eat a healthier diet if they need to, change up what they're doing. Someone said put a slice of lemon or lime in the water. It does help. That's really good. And manage their stress. So this has been really helpful. And for those of you who did ask, this is going to be, it is recorded. It will be up on our website with the slides. So feel free to go back and review some of the things that Dr. Gupta spoke about. And also you keep your eye out. Like I said, we are going to be building on these conversations with the 3 more topics. And again, we want to thank Amneal, our partners in this. And I want to thank you, Dr. Gupta, for joining us today and sharing your insights and your expertise.
Absolute pleasure. I'm sure the series is going to go very well. Thank you so much.
Thank you. And if everybody would do the wave of gratitude for Dr. Gupta, we will close it out with our thank you.
Thank you. It was absolutely.
Right. Thank you. And everybody have a great rest of your day. Bye-bye.